we were just as desperate as you guys and were looking at every scrap of evidence available. Can you silence your, can you mute your side for the minute, please? Because I'm getting an echo.
Whenever we want to speak, we can just switch on that again. That will solve.
That's much better. Can you still hear me? Just nod and tell me, can you hear me? Thank you. So what I was hoping to do was talk you through our experience. The intention here is, I know many of you are either anesthetists or intensivists or any. I'm not trying to teach you how to do your job. All I'm trying to do here is we are all learning from our experience so that you don't make the mistakes that we have already made till now and we've learned from them. That's the idea. So what we'll do is, unless you have a better suggestion, I'll go system wise and talk you through what I thought we were doing, what we think is incorrect, how we've changed it. Does that make sense? Yeah. Okay, so let's start with the respiratory system because that's the most important, right? Initially, we were being told that we should intubate everybody early. What we did initially when the patient used to come to us, they often present with a very high respiratory rate because in the UK, the advice is that if you are reasonably well, which means you're able to talk and you're not feeling breathless, then you don't need to go to the hospital. I know it is very different in India where people who are found COVID positive are being cohorted into hospitals for quarantine. That's not what's happening in the UK because you wouldn't be able to quarantine so many people in a hospital. So everybody is on a home quarantine and we are effectively relying on them being disciplined and staying at home. So that is the difference between the UK and India. However, when the patient comes to us through A&E, we, as you would do anywhere, do their SATs, and there is a pathway for referral to intensive care. The people who have SATs of less than 92% on 40% oxygen are the ones who get referred for critical care. They get referred for critical care, which is different from being accepted for critical care. Because if we took every patient with SATs of less than 92 on FiO2 of 0.4, we would be overwhelmed very quickly. So all of those patients are on our radar. We have a out of ITU patient list that we maintain, and we look at them once every shift. The consultants have gone to 12-hour resident shifts because of the extreme increase in workload that we have had. So once every 12 hours, at the time of handover between the morning and the night team, we will discuss all of those patients that have been referred to us, but not necessarily requiring ITU at the moment. The criteria for that, as I said before, SATs of under 92 on FiO2 0.4 or above. For those patients that are not on ITU, we have instituted a wake proning regimen. Awake proning, as we all know, is known to benefit in terms of improving PO2 for the same FiO2 by improving VQ mismatch. That we have seen definitely improves their PF ratio quite dramatically. Sometimes it takes more than 4 hours to work, but we recommend proning for 4 hours if the patient's able to accept it, with pillows under the chest as well as pelvis and a soft pillow under the face so that the patient's comfortable. Arms can be either up or down, whichever way they want it. Oxygen can be continued and this still need to be continued to be monitored. The one crucial thing is the patient has to be awake and able to self-prone because you don't want somebody suffocating with their ear, with their nose and mouth in a pillow and not able to talk and therefore suffocating to death. We don't want that. So There are some preconditions. I think already sent the protocol to Puneet. If you want it, we can do it again. So the awake proning protocol is available either from our hospital, which I don't think I've sent you, and the Intensive Care Society of the UK, which is available online if you need to access it and look at it. The differences between that protocol and ours is that the awake proning protocol for the Intensive Care Society suggests that you can side, as in the patient can be on the left lateral or right lateral sides. The best effect would be if the patient is actually fully prone and for as long as possible. The reason why we say as long as possible, which is up to 16, at least 16 hours in every 24, is because that's how the studies in ARDS were. And it has been shown that can sometimes take a longish period of time before proning actually has an effect. However, with these patients who are not actually ARDS at the start of the disease process, we have seen improvement in saturations very rapidly when they're proned. So within an hour, hour and a half, you start seeing improvement. This proning can continue for as long as required. As you know, about 80% of the patients will get either mild disease or moderate disease and get better and not progress on to requiring advanced respiratory therapy. We do not want awake proning to be a reason for delaying further intervention if required. So awake proning to be tried if it helps patients and their respiratory rate is under 40, they are not distressed, and the FiO2 is coming down, fantastic, carry on with it, even if it carries on for days, no trouble at all. If the patient's deteriorating and their FiO2 is increasing, then early use of positive pressure in the form of Cpap is something that we found to be very useful. As a matter of fact, um, we found it to be so useful that we have refused to enter a trial which had three limbs on it, including high flow nasal oxygen as one limb, CPAP as the second, and just oxygen by face mask as the third. The reason why we refused to enter that trial was because we have had significant experience with CPAP and we have seen patients who have avoided getting intubated, having had CPAP for 6 to 10 days with a FiO2 of up to zero point 0.7, even zero point 0.8, with a respiratory rate of maximum 40. I am not suggesting that we continue CPAP while watching multiple organ failure develop. That's not the idea. So the idea is that intubation is associated with almost a 60, possibly 70% death rate. We'll talk about intubation in a bit. The initial, what we were taught was, or what we learned from Chinese experience, which I've realized after listening to several webinars, they're not able to convey their experience too well, either because of language barrier or they are very cagey about their information. They've told us that they've only had 3,500 deaths. I don't believe that for a second. However, we have to learn from whoever has had the first experience. And I've listened to several webinars, including those from the president of the European Society of Intensive Care Medicine, Mr. Dr. Gattinoni. So this is a synthesis of what I feel we should be doing at the moment, and also what we've done wrong. So initially, just a few examples, we intubated a young man, 55 years of age, who was breathing at a rate of 45, but who had oxygen requirements of only about 40%. Intubated them early. This is a man whose whole family had got infected, and this man had lost his father only an hour before we intubated him. It has left an indelible memory on most of the ITU because that whole family got decimated. This was in the initial part when we were dealing with the outbreak, which was maybe 7, 8 weeks ago. The thing that we did wrong, in my opinion, in hindsight, is that we should not have intubated that person because, as you know, as soon as you intubate somebody, you have to use a lot of sedation. These patients don't require a normal amount of sedation when they're intubated. We are having to use high doses of propofol. Admittedly, our patients are slightly larger than the Indian population, but assuming a patient weight, average weight that we assume in UK is 70 to 80 kilos. In India, I remember we used to think 50 to 60. So taking that into account, propofol 1%, 25 to 30 mils an hour, in addition to fentanyl running at 3 to 4 mils, which is 200 micrograms an hour. In addition to that, we needed midazolam because they were not synchronizing with the ventilator, running at 4 to 5 mils an hour. That is much higher than our usual sedation requirements. They require a lot of sedation, and as we all know, sedation leads to immune compromise. It also means that the number of days on a ventilator is higher. It is very hard to do sedation holds on these patients. Some of them develop acute kidney injury as well. And the outcome from an intubation, even without acute kidney injury, is 60 to 70% death rate. Whereas the outcome from Cpap is a death rate of approximately 30%. So there's a significant difference. And therefore, we've moved on to doing Cpap first. It can last for several days. However, our criteria for intubation moving on from Cpap are: number one, worker breathing so high that the patient's getting distressed. You will note that. And number two, FIO to going to beyond 60 or 70% and the patient not improving. So those are the two criteria we're using. And that seems to be something that's holding us in good stead. That does not mean that all the patients on CPAP will not get intubated. Approximately 1/3 of the people on CPAP, depending on the severity of their illness, will get intubated. Even with these patients on CPAP, if you get their chest X-ray done, you will see bilateral, all zones involved, almost a white, horrible chest. But don't go by just that. Go by their FiO2 and their worker breathing, because most patients with COVID, you will find that it is a virus that is not lobe specific. You will find that all the lobes are involved patchily, and some of them, as the disease progresses, it becomes confluent. So it will look like a white lung almost. Just go by oxygen requirements and the worker breathing. So if the patient's deteriorating in terms of, so with CPAP, because we use either hoods or a mask, the patients usually have a high respiratory rate of 35 to 40. There is air hunger, and therefore their oral intake is reduced. We have made it a rule that we will always put a fine bore NG tube into anybody who's getting CPAP, so that we can continue with the NG feeding, so that we don't have to give extra IV fluids. I'll come to the cardiovascular side in a second. So everybody gets an NG tube so that the nutrition side is taken care of. If the patient's deteriorating on CPAP, then the decision to intubate comes into play. We do intubations in a separate ICU in an effort to reduce the aerosol in the cohorted area. All of our ITU, the 16 beds, is all COVID at the moment, and we've got another ITU now, which is non-COVID. So there isn't a problem in terms of where to intubate anymore. But at the start of the process, where we had non-COVID patients in the same area, at that time, we used to go into a side room to intubate. Now we are intubating in the bed space if it is emergency. Otherwise, try and have a side room where you can intubate patients. For that, we have made what we call as Pack A, Pack B, Pack C. So we don't want to take all the equipment inside and then it gets contaminated and you wonder about cleaning it, etc. So so the intubation plans that we made include trying to stay away from the patient's mouth and therefore not doing a direct laryngoscopy. So we use a video laryngoscope that is recommended by many people in literature, so that the person who's actually doing the intubation stays away, as far away as possible. So you're not coming close to the patient's face, you're staying away from it. So use a video laryngoscope if you have one available. If not, the process I'm going to describe will explain to you that it's actually not as aerosol generating as we think it might be if we take the adequate precautions. So what we do is oxygen by face mask for pre-oxygenation and use rapid sequence. That includes either propofol or we use ketamine depending on what your preferred choice is, because they can be cardiovascularly unstable as well. The main problem is that the senior most or the most experienced person, which who may not be the senior most, the most experienced person should be doing the intubation to give you the best chance of success in the shortest period of time. Because I have had to intubate somebody with, despite 20 minutes on CPAP with FiO2 of 1, their SATs never went above 88%. So we expected the patient to become hypoxic in the 45 seconds that it takes the muscle relaxant to act. And that patient had a cardiac arrest, short-lived, hypoxia-induced PEA. So have adrenaline ready, gave adrenaline, did CPR for in the region of 30 seconds. And because they had an arterial line, you could see that the pulse had returned. So we stopped CPR after that. But what I'm trying to explain is that sometimes there is hypoxia that does not respond to pre-oxygenation, and you have to be prepared for an arrest. Not everybody will arrest, but some might. So we just need to be prepared for that. So intubation is the quickest possible and the smoothest possible, using obviously precautions so that the operator is protected. We know that intubation is considered the most, should we say, dangerous procedure in terms of risk to the operator. But wearing proper PPE, having a FFP3 or the equivalent in India, you call it N95 mask, a visor when you're intubating because you want to protect your eyes. If you prefer goggles, that's fine. Cover hair unless you want to do a shampoo afterwards every time, and that should be adequate precautions. I have intubated more than 40 odd patients now during this COVID period, and I have done 5 COVID tracheostomies as well. So I'm speaking from experience. There is absolutely no problem. I've had not even 1 day off sick, as long as you make that decision that you are not going in without appropriate PPE. I will not ask my team to go in without appropriate PPE, and I will not go in myself either, because there is no point going in without appropriate PPE and finding that you get infected and then off sick for 2 weeks. That will decimate the team. We don't want that. Right, moving on. So we've talked about CPAP. High flow nasal oxygen is also a possibility if you want to use it. Our trust has not used it. Trust meaning the hospital. We haven't used it because it requires 30 to 40 liter flow rate, and our oxygen supplies at the height when we had lots of patients would not have held up. We have ability to have, I can't remember what, 3,000 liters per minute supply. That would have been exhausted if we had lots of patients on high flow nasal oxygen. However, now that the number of patients has reduced, if somebody wants to use high flow nasal oxygen and use the slight PEEP that it offers, that is an accepted parameter. We've talked about when we intubate. I've said that we try non-invasive techniques first. We made the mistake of intubating patients early. The other mistake we made was extubating patients early. So the initial lot of patients, their FiO2 went down to 35-40%. Respiratory rate was 30 or less, which normally satisfies our criteria for extubation when their PEEP was not too high at about 5 to 8. So we thought we'd extubate them. We extubated them at that time and they got reintubated very quickly. This was day 6 or 7 or even day 5 post intubation. In non-COVID times, they would have satisfied the criteria for extubation, and we could not understand why we were having to reintubate them. Now in hindsight, there is more evidence coming out that these patients have swollen airways. So now we use dexamethasone 8 milligrams 3 times a day for 48 hours if somebody is coming close to the possibility of extubation. Number 2, we can use adrenaline nebs if required. And number 3, you can extubate onto CPAP if required. But in hindsight, I think some of those patients who improved dramatically quite quickly in the first few days were actually the ones who should never have been intubated in the first place and could have managed with CPAP. But hindsight's a wonderful thing. Anyhow, that is the reason for this conversation, so that you don't make the same mistakes yourself. You might make them, but then you learn from them. And having heard our experiences, you'll be able to put two and two together quickly. So that's the respiratory system. In terms of ventilation, they are not like the ARDS that we were told they are. They've got fairly compliant lungs and don't require PEEPs of 15s and 20s initially, in the initial part of the disease process. So 6 to 7 to 10 days of post intubation, they actually have very compliant lungs. The airway pressures are not very high. We do protective lung ventilation where we follow a strategy of starting them on volume control SIMV and use 8 mils per kilo tidal volume to start, and then if stable, reduce it to 6 mils per kilo. That is our ventilatory strategy at the start. We use PF ratios to guide a change to a strategy where our airway pressures where the airway pressures need to go up because this strategy is not working. So if the PF ratio drops to under 12, oh, that's in English terms because we calculate it in kPas. So for you, if the PF ratio drops below about 150, I'm assuming you work in millimeters of mercury like we used to in India. Is that right? So PO2 is millimeters of mercury or kPa for you guys? Which one? Yep, I can hear you.
Millimeters of mercury.
Thank you. Yeah, so if the PF ratio is less than 150, we need to think about strategies which are more like the usual ARDS. So we go on to either bi-level with a high lower PEEP as well as a higher PEEP with a IE ratio of 2:1 or even 3:1, so inverse ratio, or we go with APRV. I don't know whether you guys use that or not, but that is our mainstay of management to increase our pulmonary airway pressures so that we can oxygenate the patient. There are patients who will not respond, and you'll find that those are the guys whose x-rays are really horrible, and also that those would be the guys who are likely to show more coagulation abnormalities. So that brings me to the second aspect. This disease is, I think, a disease of rampant coagulation, both micro and macro. We've seen a significant, initially, I'll tell you about the initial experience. So initially, we were using the standard dose that we used for anticoagulation in an intubated patient, which is low molecular weight heparin at 40 milligrams subcutaneously once a day. There was lots of patients who developed either blue tips of fingers, or the forearm would go completely blotchy and blue, like, if you see patients with high doses of NORAD or adrenaline, poor circulatory state. And we did not know what was going on. You try put an arterial line and the blood's clotting in front of you as you're putting the line in. Put in a vascath to do filtration, and we were going through the filters clotting every 2 or 3 hours, and we didn't know what to do. What we've done now, in hindsight and after discussion, because everything in the NHS happens after a lot of deliberation, it took quite a long time. But what we've done now is increased our anticoagulation on everybody who is either confirmed or suspected COVID, so that instead of the 40 milligrams once a day, we've increased the dose, not quite to treatment dose, because there were instances of people bleeding, hemorrhagic strokes, and otherwise gut bleeding, etc., etc. We lost a few patients. Other hospitals have also lost a few, but not as many as you would expect. However, what we've done is gone to in between what we used to do as the prophylactic and treatment dose Clexane, low molecular weight heparin. So instead of the 1.5 milligrams per kilo, and not the prophylactic dose of 40 either, in the region of about zero point 0.8 to 1 milligrams per kilo, dependent on, we get it in syringes of 40 or 80. So we either use 40 milligrams BD in somebody who's 80 kilos or above, or if somebody is more than 100 kilos, we go to 60 milligrams BD. If somebody is more than 120 kilos, then we go to 80 milligrams BD. If somebody's got a low eGFR of less than 30, then we stick to the low dose that we used to use, which is 20 milligrams once a day. In those patients, we can also put intermittent compression devices, the floatrons as we call them. I don't know what you call them. So it's like on the cuff, which is an intermittent compression device. I don't know whether you have it or not, but if you have it, you can use it. If you don't, that's fine. That's more important for the patients who've got a low eGFR, because patients with a low eGFR, you can't really give too much low molecular weight heparin. So that's the clotting side of things. We've also added low dose aspirin, 300 milligrams as a loading dose, followed by 75 milligrams once a day, because the platelets are quite sticky. We've not seen any patient with a consumptive coagulopathy. The platelet counts in all of our patients have been high, not low. The reason why I mentioned this is because there was lots of literature saying that this is a DIC with a consumptive coagulopathy with low platelet counts. We haven't seen that. We've seen high platelet counts. Moving on to fluid balance and cardiovascular system. Most of them are cardiovascularly very stable. However, we try and keep the lungs on the dry side for better gas exchange. However, we were drying them out too much initially and found that lots of patients were going into acute kidney injury. Now there is a developing consensus amongst the ITU fraternity here that they should be kept euvolemic. Effectively, what I mean by that is give an adequate amount of fluid, especially when they've been panting for 3 or 4 or 5 days with a high respiratory rate. They would have had lots of insensible losses. If you find urine outputs low, we tend to do a straight leg raise to assess for fluid responsiveness, so that we don't actually have to give a fluid challenge first. So we do a straight leg raise and give an adequate amount of fluid, 500 milligram boluses 2 or 3 times to fill them up. 90 times out of 100, that intervention improves their urine output and corrects their acute kidney injury with the improving urine output. We did the mistake of drying them out and giving very high airway pressures in the beginning. That led to a higher incidence of acute kidney injury. And the data coming out is that if somebody's got an acute kidney injury in addition to intubation, their death rate goes up to 80%. So we need to try and avoid acute kidney injury if we can. And the way to do that is to keep them euvolemic, not dramatically underfilled. To nuance that argument, if somebody is passing adequate amounts of urine and have a reasonable eGFR, then I would try and keep them on the drier side. If their eGFR is reducing dramatically with this initial strategy, then assess if they are fluid responsive and fill them up to avoid the requirement for vasopressors. If you do require vasopressors, we use noradrenaline as a first choice. Metaraminol if they don't have a center line. I know we don't have metaraminol in India. We used to call it something else. I've forgotten now, being here so long. Whatever vasopressor you normally tend to use is fine. And NORAD if the peripheral vasopressor doesn't work. Try and maintain your blood pressure effectively using as little fluid as you can, but equally don't run them too dry is the message. Next is they often tend to have a temperature. And how do you differentiate between whether it's superadded bacterial infection or just the COVID virus causing trouble? Solution for that is we've started doing procalcitonin. And if we have a procalcitonin value of less than 0.5, we stop antibiotics. Otherwise, we treat them as a community-acquired pneumonia and treat them according to whatever schedule you follow. In the UK, antibiotics are very tightly controlled, and therefore we tend to use coamoxiclav with, I know it won't even work in your settings, I suspect, with the multi-drug resistance. So use whatever antibiotics your microbiologist suggests. So we've talked about the cardiovascular system, respiratory, renal, coagulation, feed them, and we've talked about awake proning. Um, I think I've covered most things. If you want to turn on the get rid of the mute and ask questions, and if there's something that we haven't discussed, we can.
Doctor, I would like to know what are you giving for COVID per se? Any antiviral drug?
Okay, so there is no evidence of any antiviral drugs at the moment that we are using. We are using remdesivir, but that is only as a part of a randomized controlled trial protocol. We are not using hydroxychloroquine. We were using it initially, but there are very many studies that have come out saying that it is equivocal and doesn't help. I know it is being used extensively in India. I'm not telling you not to use it. I'm just telling you that my own experience is zero with antivirals because the, we only use things in the NHS once there is conclusive evidence. They won't allow it. If I prescribe it today, either pharmacy will stop it or the clinical advisory group, which has overview, will stop it. I had tried to initially start using hydroxychloroquine plus minus azithromycin. We prescribed it after getting a microbiologist on board, but the clinical advisory group stopped it because there's no evidence. The other thing that they're starting to use again as a part of the trial, which we have used to some extent now, but very little experience, personal experience, is convalescent plasma. And that's because we've enrolled in a trial where convalescent plasma is being used to see whether it make a difference.
So it means no antiviral or hydrochloroquine is not working. So it's basically the ARDS net protocol type of just support.
Yes. So it is effectively just supportive care, and we have been quite, feeling quite desperate that patients were dying in front of us. We had a fairly high death rate in the initial bits, but now it has reduced, and we have been encouraged by the changes that I've described in terms of not jumping into intubate too early. I'm not saying you watch multiple organ failure develop, but don't intubate from face mask, don't just go on to intubation. Number two, I think a significant difference has been the anticoagulation that has been increased. There was one patient who lost their leg. There have been several saddle emboli that we've seen. So if there is a sudden deterioration in an intubated patient where their FiO2 has gone from say 60% to suddenly 100, have a high index of suspicion for a PE. And other than that, yeah, maintaining euvolemia as opposed to keeping them very dry, those 2 or 3 interventions have made a significant difference in the outcome. And it is, as you say correctly, just supportive management.
What point they're introducing steroids?
Yeah, you told us that you were introducing steroids early in the phase or later when you said dexamethasone early kind of.
Yeah, so again, there is not much evidence that steroids improve outcome. They are a part of the recovery trial as one of the arms. The dexamethasone that I mentioned is 8 milligrams 3 times a day for 48 hours when the patient's getting ready or suitable for extubation. So that will be much later. These guys are ventilated for 14 days up to 21, 22 days as well. So it's not a disease process that finishes quickly. The only other steroids that we have used has been methylprednisolone pulse therapy, and that is in the medium sort of part of the illness, which is post day 7 or 8. And the thought process there was that there wasn't much fibrosis in the lung, and methylprednisolone 500 milligrams once a day for 3 days has improved patients in that situation. there is a consideration that using steroids too early